Hi, welcome back to DEBAKEY CV Live, Sisterhood and Surgery, our final episode before we take a break for the summer. I'm here with my co-host, Palma Shaw, and how fitting it is our topic today, climbing Mount Everest and reaching the peak in vascular surgery, one woman's journey, going out with a bang, I would say. And I'm privileged and honored that Dr. Julie Freischlag, who really needs no introduction, is our special guest today. Remember, this is a live event, so you can text your questions in for Dr. Freischlag. She said you can ask anything and she'll answer it. So you can go to pollev.com, enter DEBAKEY, or join by your phone via text to 37607 and text in your text message. And Palma, would you like to start the introduction?
Thank you very much, Linda. And thank you, Julie, for spending valuable time with us tonight. So I'd like to give you some introduction. So Dr. Julie Freischlag is the Chief Executive Officer at Wake Forest Baptist Health, Dean of Wake Forest School of Medicine, and the Chief Academic Officer of Atrium Health Enterprise. As CEO and Dean, she has the overall responsibility for the health system's clinical, academic, and innovation enterprises, and its annual operating budget of $3 billion. Previously, Dr. Freischlag was Vice Chancellor for Human Health Sciences and Dean of the School of Medicine at UC Davis. Dr. Freischlag has helped to drive change in academic medicine with a deep commitment to diversity and inclusion. For more than 15 years, she has led education and training programs at top medical schools in her role as Professor and Chair of Surgery and Vascular Surgery departments. She also has more than 30 years of experience leading patient care services as Chief of Surgery or Vascular Surgery at nationally ranked hospitals. She has served as Professor, Chair of the Surgery Department, and Surgeon-in-Chief at Johns Hopkins Medical Institutions. She led initiatives to expand research, add specialty clinical services, improve patient-centered care and patient safety, redesign the surgical training program, and enhance academic career paths for faculty. Her national leadership includes serving as a former governor and secretary of the Board of Governors and a regent and past chair of the Board of Regents of the American College of Surgeons. She is the past president of the Society for Vascular Surgery and the Society for Vascular Surgery Foundation, and past president of the Association of VA Surgeons and Society of Surgical Chairs. Dr. Freischlag was the editor of JAMA Surgery for 10 years, from 2005 through 2014, and is currently a member of the JAMA Oversight Committee and the editorial boards of the Annals of Vascular Surgery, Journal of the American College of Surgeons, British Journal of Surgery, and the Journal of the American Medical Association. Linda?
She also has published more than 300 manuscripts, abstracts, and book chapters addressing both medical topics, but as well as burnout and work-life balance. She's an internationally recognized expert in the treatment of TOS, and she continues to evaluate and treat thoracic outlet syndrome patients in a registry. She's received numerous teaching awards, including an Achievement Award from the Department of Veteran Affairs, and was elected to the National Academy of Medicine in 2015. I would say she's dedicated her career to serving as a role model for her students, a respected colleague across health professions, a strong community leader, a national voice for improving health and healthcare, a mom, and a grandmother, and she's currently president-elect for the American College of Surgeons and also serves on the board of directors of the Association for American Medical Colleges, National Institute of Health Clinical Center Research Hospital Board, the Aga Khan University Board of Trustees, University of Pittsburgh School of Medicine Advisory Board, the University of Illinois Health Advisory Board, and the American Hospital Association Changing Workforce Task Force. So let's begin. Palma?
Julie, what you've accomplished in your career is unparalleled by any woman in vascular surgery and by any woman that we know. We felt that you could not only empower women, but could comment on challenges that you have faced. So we'd like to pose some questions to you. When you started, did you have the vision to get where you are now? I mean, did you have any idea that you would get to this position? What was your vision at that time?
Well, thank you so much for having me here, and it's delightful to chat with many of you, because the future is all of you out there, and my thoughts as far as where I came from, I sort of finished training in the late 80s, and at that time, I was only the sixth woman to get her vascular certificate. So it was a different time. And I was only the sixth woman to ever finish UCLA general surgery at the time. So at first, I just wanted to be a really good doctor. And if the advice I could give you is whatever you decide to do, just go be really good at it, because they can't take that away from you. My mom was an elementary school teacher, and when I skipped first grade years ago, she said, you need education. If you get educated, they can't take anything away from you. So I just really wanted to be a great vascular surgeon. And as I kept going forward, realizing that I wanted to sort of reorganize how things were done. I think I've always been a very inclusive leader. So you would want teams at work, even before timeouts and the other things that we did, that working in a team was my thing, because I came through a pyramidal program, right? And we got cut. There were 14 of us cut to 6. We were every other night in house. So it was diabolical, actually, in the 80s. We thought it was the right way to train. But when it got to be an opportunity to make it a different, inclusive environment, I took it. And I think the things that have driven me to change what I did is I always want to learn something. So whatever job you have, make sure you're still learning, whether it's clinical, research, education, or administration. Make sure you have a great boss. I had a series of really great bosses as I went through UCLA with Wes Moore, and then Johnstown when I worked at Medical College at Wisconsin, and then Ed Miller, who was the dean at Hopkins, who gave me the chance. And then always assess how much impact you're making. Your job, especially if you are someone that looks a little different, comes from a different place, is to tell people what you feel, because your difference of opinion will make all the difference in the world for the people that come behind you.
Can you comment on your development as a leader, and how has this changed over time in your different roles? And what would you say would be your number one piece of advice for women or anybody out there who look to become a leader? I mean, is there something that just makes you grow as a leader?
That's a great question, and I think for surgeons, we really undervaluate what you have to do every day in the OR. If you think about it, you've got a surgeon, you have an anesthesiologist, and you have a nurse. You have 3 specialties that are huddled around a table breathing the same air, right? And lots of times what you have to do is stressful. It's ruptured, it's clotted, it doesn't go well, especially in vascular surgery. And you have to organize that team to get the job done in a way that makes it work well. And if you've been in ORs where there's chaos or people yelling or it's not going well, you can see how inefficient that is and not good for the patient. So being able to run a wonderful OR, I actually think equates to being able to run 20,000 people like I do now and running multi-disciplines, because you have to trust those around you. You have to empower everybody to work above their pay grade so that they can get the work done. And then you also have to be a great communicator. So you have to be able to explain what's wrong with that patient. Why does everybody need to be quiet right now? Because you're bleeding. You need to tell them you need to get that clamp on fast. You need to tell the story of the patient and why they're there for their intervention. So I think the communication piece in the operating room really got me, so that you can quickly tell people where you're going, why you're going. And you also have to listen. I think as residents, sometimes we move so fast that we forgot to listen. You were trying to get things done. You were trying to be authoritative. But probably the best thing as a leader is to listen, and to listen well. I do have a superpower. If you're at a cocktail party with me, I can listen to 3 or 4 conversations at the same time and hear everything you say. And so I can actually text on my phone, talk on my phone, listen to everybody. I actually never miss a trick. And I think learning out to be a really good listener is important. And I think the thing that's changed in my leadership style over the last 20 years for sure is having a huge amount of appreciative inquiry. So when people tell you something, being able to follow that up with a question, because frequently what they just told you is not what they want to tell you. It's just the beginning. It's the preamble. It's sort of like when someone says, do you have a minute? Usually they need an hour. And if you have a 30-minute meeting, they usually tell you what they need to tell you at 5 minutes to the hour. So make sure you ask some leading questions so that they will tell you what you need to know. And lastly, I think I'll add vulnerability. I think training as a surgeon, we never wanted to admit we made a mistake. When I trained, you certainly didn't, because you would probably get fired. So trying to do everything perfectly, being really hard on yourself, really trying to make it perfect all the time was sort of how I trained. But telling stories about what didn't go well and being vulnerable, I think really helps those around you to tell you when things are not good, to tell you the truth, to make sure that you know when something's wrong. I was on vacation last week and we had a big issue here, and my president didn't flinch and texting me saying, I got to tell you something, because he knew I needed to know. And of course I needed to know. He was taking care of it, but he knew to just call me. And so I think part of it is to have that availability and vulnerability so people trust you and tell you things, because you make great decisions if you have all the information, just like you would with a patient. You need to see all the scans. You need to look at the x-rays yourself. You need to talk to that patient yourself to understand their symptoms. So I think to be a leader, you have to do exactly the same thing.
That's really great advice, Julie. What I'd like to ask you is, having been in so many different, not only jobs, but different parts of the country, I can't imagine the cultural differences that you've encountered between these different institutions, West Coast, East Coast, Midwest, now South. I mean, that's all a challenge. Even if you went from one major hospital to the other in the same state, it's still a challenge culturally. I mean, how did you manage that?
Yeah, that's a good question. And part of it, so I went to college in Illinois and went to Rush Medical College. And I actually did some away rotations as a student. And I really wanted to go to California. It was sort of a dream come true. And when I matched at UCLA, I actually really wanted to go to UCSF, but I found out later they didn't rank any women that year. So no woman got ranked. And when they matched me, they had actually dropped my slip of paper on the floor because I had actually been on call the night before. So when I finally got my match, it was great. But I loved UCLA because they had just finished a woman resident the year before, Marjorie's Fine, and she's wonderful. We still communicate. She's retired now, but still does surgery overseas. And I knew they had trained one woman. So that actually was good to see, in the sense that there were some women being trained. Los Angeles was pretty progressive at that time. I thought that I don't remember not being treated equally bad, I guess, because we were on call every night to do that. When I think back, I don't remember not getting the opportunity to do cases, not doing that. But I think I do have, there's something about it that if people tell me I can't do something, I decide to do it even better, so they would never think or make that happen. I did move mainly for opportunity for jobs. My first job was because I was married, and he took a fellowship in San Diego. Then we got divorced after we moved back to Los Angeles. So I moved to Milwaukee, mainly to go back into the Midwest. And John Town was a great partner who gave me great advantage. But I was only one of two women on faculty there, and only woman on faculty at both UCLA and UCSD at that time. So part of it was learning how to navigate those waters sort of on your own, and partnering with other women in the institution, such as the lawyers, the HR people, the nurses, finding other amazing women in the hospital system that could be available to answer your questions, be your friend, have something in common. Then I actually started looking at division chief jobs because John Town wasn't moving. And actually probably the second hardest job I took was going back to UCLA and running the people that trained me. They gave me a whole set of skills of telling those who used to teach me what to do, but it gave me the ability, again, to really listen and to have a strategic plan of how we were going to make the division incredibly good in research, education, and clinical care. The chair jobs I actually started looking at because George Sheldon told me I should. He was the chair at UNC. And I looked at quite a few and had people tell me they couldn't hire me because I was a woman. And when someone tells you that, you really don't want to work for them anyway. But even as late as 2002, I had a dean tell me that he couldn't hire me as chair of surgery because he hadn't had any women chairs yet. So then you find somebody like Ed Miller who said, come to Hopkins and change the world. And that was my hardest job. Those first 3 years at Hopkins, which is steeped in tradition, had to have great outcomes, great residents, great program, but really needed to be invigorated in how we would go forward with it. I showed up with the 80-hour work week and timeouts, and many of them thought it was all my idea. But I actually was able to, I spent 11 years there really cultivating change, and I think really helped people see that women can lead surgery. And so now there's over 20 women chairs of surgery, not so many women chiefs of vascular. There's still less than 10. And when I was chief of vascular, I was the only one in the country for those 5 years. But now after I finished the chair jobs, again, it's sort of that, I wanted to learn something new. I wanted to be dean at Hopkins, but they chose someone else. I stayed about a year, but I decided I really wanted to go somewhere where I could learn something different and went out to UC Davis. But these jobs are fraught with hazard. You know, my chancellor got fired out there by the president of the university, and you do the math. The chancellor hired me, the president fired her. I think I need a new job. And then I came out here really to work for Nathan Hatch, who's president of Wake Forest University, and to be CEO, and then became dean because the dean moved on as well too, and to really learn healthcare. So I think part of it was opportunity. My husband would move with me, so I got remarried in Milwaukee. My son had finished high school in Baltimore, so it was okay for us to move. But I also moved a lot as a kid. I went to 3 grade schools, 3 high schools. So maybe it's just the nature of me that I need to move around. I'm not sure. Everybody thought I'd have trouble in the South, Palma, that this would be really hard to come to Wake Forest, because it's in Winston-Salem. But I'll tell you, I have had very little issue with gender here, partly because I have good credentials. I'm easy to talk to. I still operate a bit. I still do first ribs. I'm doing one tomorrow. I'm that person that they look up to, that they needed to change. So I actually think when you do have a good track record of who you are and what you do, and that you actually come in listening so that you do change some things, but not all. My team is basically everybody that was on the team except for 2. But I did have to fire 5 chairs my first year. So you do have to make moves, but do it in a way that people know why you're doing it. So I actually have enjoyed all the different cultures. I've enjoyed everywhere I lived, but I mainly like it here because it doesn't snow here, Palma. So it's actually, or a little bit, we have a little bit of snow. My first year, they had a record snow and I was like, I'm out of here. But it's a very great patient, great training program and very collaborative chairs. But you're right, culture is great, but I think I thrive in learning new ways to do things and again, listening to how you can affect change, but keeping the good things that are there.
So what was one of your most difficult decisions that you had to make as a leader?
Yeah, probably the toughest one is when I got here, I had a CFO that lied to me and I fired him in 5 weeks. And it was hard. He was here. I had to tell my board because I have a fiduciary board. They all thought he was great. And I had to I was only 5 weeks old, but I knew he wasn't the person for me. That was really hard. But it also gave me great strength because I did it on a Monday. So people thought, whoa, to do that. But I think that's always hard is when someone disappoints you and you have to tell them they're in the wrong spot. Even with removing chairs, telling people they're not in the right spot. About half those people don't have insight into what the problem is. So you can actually talk a long time to them about what the issue is. But the bottom line is they don't have any insight. Some of them will find another spot that works to do it. But I think recognizing something early, you never want to wait with that decision. You always want to go ahead and get that done so that you move forward with a different way. Because people that are not honest or can't work with you are not going to make you successful at all. So those are probably the hardest ones. Probably the second hardest is if you have a trainee that isn't excelling or making the grade as they promote, especially, in vascular and cardiovascular. You have to be a really good technician, and having to sit with some residents and tell them that they're really in the wrong spot. Now, they all find the right spot, but telling them that they're so disappointed that they can't do the job or they have an issue, that's probably really hard. If they have a professional issue or they don't tell the truth, that's not as hard, because that is something that you don't want around you. But when someone just doesn't have the ability to do what they think they want to do, finding them another spot, I think that's hard too. They all do, but the hours you'll spend getting them there is very difficult. And they'll thank you later. Most times they don't thank you right away because they're not very happy with you. But then they'll thank you months to years later that they're in a good spot.
Julie, how do you manage your time in reading your bio and everything that you do? I can't imagine how you fit everything into your calendar. So how do you compartmentalize, prioritize? When do you say no and when do you say yes?
Yeah, that's a great question.
Sleep.
And partly, I think I do compartmentalize really well. And I tell young people, you really need to have time management skills. Now, you have one of these, so you can do that. I used to have a paper one years ago to do it. And I think part of the time management is you got to figure out what time of day do you get things done best. And so there's a new book out by Daniel Pink that's called When, and he's the one that wrote Drive, about why you do what you do, but it's all about time management. And for me, I'm a morning person. A lot of surgeons are, because that's who I am. And that's when I can be most creative. That's when I can write. That's when I can think clearly and strategize. And I tend to be able to do that for an hour or two. I'm not a 4 or 5 hour writer. I do it for a period of time. And the worst time for me is late afternoon. I'm sort of tired. I really don't want to make any decisions. So if you come see me, I'll probably say no to do it. So knowing the time of day that you're best to do that. You also need to figure out how much you should sleep. And for surgeons, that's really hard to talk about, because all of us love to say how we've been up all night and we didn't sleep. But especially as you get older, you have to figure out how much you need to sleep. And I need 7.5 hours of sleep. If I go to bed at 10, I will wake up at 5:30. If I go to 11, I really need to go to 6:30. And everybody's got a different amount of sleep. And the sleep you get actually makes you quicker. I think it makes you a better listener. And it also makes you, when I wake up in the morning, actually, Sharmila, who is the chair of surgery in Texas at El Paso, she actually taught me to take a deep breath and do 5 minutes of meditation in the morning, and to think about all the good things you're going to do in the day, all the good things in the world, and to wake up and energized for what's going to be happening in that day. And that has really helped me a lot. She really gave me quite a bit of insight into that. I also am extremely organized. I have my calendar mapped up. It's usually in 6-month intervals. So I used to know where I'm traveling. We don't travel that much anymore, but we'll start up again, right? I make sure I schedule my cases and my clinics in an appropriate time for me. I have routine meetings with people, so there's no urgent emergent meetings. So I have routine meetings with chairs and people every other month, standing meetings every week with my team. And now with this, COVID-19 hasn't done much for us, but it has made it more flexible. So we allow people to do virtual. COVID-19 was really tough on women, mainly because of kids and parents and trying no school. But I think in the future, it's going to really help us, because you can say, I can't come to the meeting, but can I be virtual? So I just had a meeting with my pediatrics group, and half of them were on the screen, half were there. And it's really great. So you can have some. I do think we need to get back to in-person meetings. I think we really miss a lot of creativity and interpersonal relationships by not having that. But I do think that this will give us a lot more flexibility. But you do need to be careful that you don't schedule too much, because you can do it virtual to do that. But I'm very organized, and I know where my meetings are. I know what holidays I'm taking. I know My husband does all the cooking, so I don't manage the kitchen whatsoever, but I haven't cleaned my house since 1983, and I have no intentions of doing that. My son actually was in daycare when he was younger, but I had a lot of camps and scheduled activities. And I do take vacations. I have always with my family, so you have those memories. And he thinks of those often, that he remembers the time that I disconnected from work. I tended never to work at home, so I would wait till I was done for the day and come home a little late. So this has been hard for me to work from home. I did it for a few months right when COVID started last year, but it's not my thing. I really work better in the office. And so coming to the office, I'm very focused, get it done. And then when I go home, I might be a little bit, but not much. When I travel, I tend to work when I go somewhere. And when I come back, I read a book. I read a lot of books. And so I give myself a gift of a book when I'm reading, and COVID has made it so I haven't read as much. I'm just starting to read again. I think I was a little unfocused. I think organization, and as you saw tonight, I have great help. You have to delegate to your assistant. So I have 2 assistants here, and Carla started this. I let her write, make decisions. Let your assistants make as many decisions as you can let them. Let them schedule, let them write, let them do memos, let them do all those things that don't make much difference if it's not perfect, but you just need a message out. They know they speak for me, and my people that work for me know just what I like and don't like, so they don't have to have everything approved by me. So I think the more you can trust your team to go out and do things, the better off it'll be too.
So we have a question from the audience, and the question is, Julie, did you worry about stepping on other women's toes when competing for a job when women weren't getting hired?
Yeah, and that's a good question. That I think they call that queen bee. Where when I started, there was a feeling, it wasn't spoken out loud, that maybe there's only room for one woman. That on the team, maybe there should be only one woman partner, or there should be only one woman chair, or if there is a woman, that they won't hire another one. So if they hire her, they're not going to hire me. And now part of that is there weren't that many women. So when I was out looking, frequently I was the only woman candidate. When I interviewed at UCLA for surgery, I was the only woman in the room. Don Morton said, "Welcome all young men and one woman." There it was. So for me, there weren't many women to step on toes of, because there weren't any. But over the last 10 years, there's a lot more women out there in the workforce that can lead. And frankly, I have enjoyed that. I do a lot of mentoring for women to take on those jobs. And actually, I've been quoted recently in an article saying that you just got to raise your hand. I've been the only woman president of the SBS, and that was a long time ago. I was president almost 10 years ago. And so part of it is I think we need to just raise our hand and go do that. I think Palma asked me when to say no. And the thing is, I think you ought to say yes a lot, but then you need to dump something you're doing. So if you do say yes, I'm going to be, I think Kathy DeAngelis came to me and said, "Can you be the editor of JAMA Surgery," at that time, Archives of Surgery? And I was 2 years into the chair of surgery at Hopkins. And I said, "I don't have time for this." She goes, "Oh, yes, you do." And I did that every morning, where I'd read the articles. It kept me up to date. It was great to do that. And I enjoyed it, actually. It was a joy part of my life. But then you have to give up something else. You can't, and don't worry that you were no longer on the editorial board of Annals. I was never asked to be on the editorial board of JVS, just to let you know, to do it. So I went off and ran my own journal, So I think part of it is you need to say yes and then give up something. The other thing I do, which gives me incredible joy, is if someone calls for me to do something now, where I don't have time or I don't really need something else to do, I get to suggest someone else. And that's where you can have an opportunity to suggest men and women for those jobs. But I make sure that I give them a nice list of people that can be the chair, that can run the meeting, that can be on the panel, that can write the book chapter, whatever it is. I don't say no, I just say, yes, I could do it, but could Palma be first author? And she will write it, I'll be senior author. I did that so much during COVID, I forgot which chapters I said yes to, so it got a little confusing. I think it was a COVID thing, but I think promoting others is now something I really enjoy doing. I don't think I ever competed for a job that there was a second woman candidate. which is sort of sad, right, to do it. There might have been one for this job where I am now. I'm not sure, but there may have been a woman on the slate. But the other jobs I looked at, there was never a woman candidate, but now there will be. And many people feel that if there's more than one woman candidate, there's a more chance that a woman might get the job. So having 2 or 3 women candidates, I think is a good thing.
So Julie, in a lot of the things you've said, I think feed into this question I have here. So can you comment on how hard it is to make the transition up the ladder from manager to CEO? So just as an example, right? And you've managed to transition from chief of vascular surgery to a chair of surgery to a dean, now CEO. You've been the SVS first president, only president, and now president-elect for the American College of Surgeons. So when I think of all those roles, I feel like it would take me 3 lifetimes to do all these things that you've done. It's just so incredible. But I wonder if it's, what is your toolbox? So the things that you've mentioned, this incredible organizational ability, this ability to strategize, this knowing yourself, knowing when you're at your best, how you could be most efficient, when not to try to do those things. I mean, is there like a toolbox you have that we could just use for all these things? You just plug it in and that just seems to work every time.
Yeah. Well, I think if you aim for joy of your day, you'll be able to have the toolbox that you need. So when you look at your day, one of my mentors, Bruce Stabile, who hired me actually in San Diego, my first job, because my first husband was a fellow there, he used to tell me that if 50% of your day is good stuff, that you're enjoying it, that is a perfect job, because you really aren't ever going to get 100%. So when you think about your day as you go through your life, I thought about when I was part of a division of vascular surgery, that I wanted to start making some of those decisions. And what are those decisions? You know, how you choose the fellows, you know, how you do the rotation, the call schedule, how are you going to run your research lab? So what decisions do you want to make that will make you joyful? What do you want to accomplish? Are you a clinical surgeon and just being in the OR every single day is just delights you? That makes your heart sing. And many surgeons are like that. They want to operate every day, and that's what makes their heart sing. When I was at Hopkins, I learned how to run the operating rooms. That's right when we started looking at variability in ORs, safety and quality. And I found that I got a lot of joy out of that, knowing we were really helping patients be safe in the hospital. So that gave me joy, and also gave it so that more people could get surgery, more surgeons could get home at night. It was a good thing to do. So I think looking at joy, looking at what gives you joy and what's going to get you there from here, and then trying not to spend a lot of your time doing unjoyful things. So when I didn't get the dean at Hopkins, there were about 10 of us that wanted it, and all of us are now scattered around the country. For a year, I reported to the new dean, and he thought I did a great job as chair of surgery and wanted me to stay on. But I realized I wanted to make his decisions. I wanted to impact medical students. I wanted to look at research portfolios. I wanted to expand. Since we've been here, we've bought 2 hospitals, and now we're partnering with Atrium, looking at can we make healthcare systems transform so they're cheaper and better and easier for patients to navigate. And after about a year, I decided I wasn't real happy because I wanted to make his decision. And so no matter what decision he made, I wanted to do it. And so that's when I went out to UC Davis to be the dean and to learn more about undergraduate education, which I must admit I'd forgotten since I'd been one. And so I got to work at the undergrad campus with the chancellor, Linda Kategi, who was an electrical engineer, and really think about those kids coming through college. How do you get them into med school and make them great doctors? So I think that's where it is. And I think you need different tools every 5 to 8 years, you know, so your tools as a young faculty is to be a great surgeon. So you need to work with your Castro-Viejos and your endovascular techniques, and you need to be able to get that clamp on the aorta. You need to be able to talk to those patients and care and concern. And you need, if you are in an academic setting, you need to teach that to the person standing next to you and enjoy that. And then if you're doing research, you know, you need to get funded. And I did a lot of basic science research. I smoked rabbits for a while and looked at reperfusion and neutrophil activity, and all of that was great, but I realized that wasn't going to be my biggest contribution. It was a wonderful way to learn about arteries and veins and reperfusion, but it wasn't where I wanted to go for the next 20 years. And then you pull out of your tool bag other opportunities. Now, I do not have an MBA, and people ask me all the time, do you need one? And I think it's great to have one. I actually just have 4 on my team. So I have 4 MBAs here. I had 1 MBA at Hopkins, and the MBA I worked with at Davis was great too, so that I can understand, funds flow, what goes on with research, what goes on with philanthropy. I'm a really good fundraiser to do that. I enjoy that. So I do think you have to change your tools in and out, but assess yourself every few months. Is this joyful? If you get a new chair of surgery, a new division chief, you have a new partner, is it good for you? Do you need to be somewhere else? Is it okay for your family? Is it okay for you? And I think that's where my assessment was. Now, my husband has traveled with me. I met him in Milwaukee, and he's gone to Los Angeles, Baltimore, then to Sacramento and here. And he actually wrote a little essay for his high school reunion, and I was a little scared to read it because, he was born and raised in Milwaukee, and I drug him across the country. And he wrote that it's been such an adventure, that he's enjoyed every minute of it. And he's my best aspect. He's just a wonderful person. So part of it is to make sure that you make it your best adventure, that you keep trying to add more to your toolkit so you understand, like international medicine. I'm on an Aga Khan board now, and I've been over to Pakistan and Kenya to look at how they deliver healthcare. And so I think part of it is that joy, new tools, and don't be scared to move on to something new. Now, some people want 30 years of the same thing. And that's good too. Just keep checking in, saying, I love this. I love this. And we have many people that practice and work in the same place with the same job. And they're really good teachers and fellows. They're really good researchers. And then there's others of us that really want a little bit more adventure to that. Just figure out which person you are.
So before the show, we were talking, just chit-chatting, and you said you would, talk about what, your divorce or your in vitro. I really want to hear your fertility story, just because we had an episode on that, and,
Sure.
I just think sharing that, there's so many women out there that are, in training that are, starting to think, well, do I want children, and am I going to have issues with it? And women that are, my age that are having so much trouble having children. So I think it'd be fascinating to hear what you went through. Sure.
So when I first started, most women, there weren't that many women, right, to do it. So a lot of them didn't have children. So I'm 66, so women that have trained that are older than me, many did not have kids, just because of the nature of things and the struggle, and probably the harassment about it, in the sense that we're told if you want to have kids, you can't be a surgeon, to do that. So when I trained, I was single when I went out to Los Angeles. I had been engaged for a bit, but moved on. And so I really didn't think about it much. Got married to a guy I met when I was a sub-I down in Arizona. He was an internal medicine person, and we were married for about 7 years. And probably the biggest story about that was we went into some counseling because I went down to San Diego for him. We came back to Los Angeles, where I was chief of vascular at the VA there. And he said, well, if you give up surgery, this will work out fine. And I was like, what? And so Jane, our therapist, after he left, she goes, that's just not going to work for you. You need to get rid of him because you are a surgeon. That's what you do. And so that's when I actually took a job and moved to Milwaukee, joined a dating service. That was before it was online. Went out with about 12 guys because I was in my mid to late 30s, and met my present husband, Phil, on one date. And we had a date in August, engaged in December, married in April. Now we've been married 28 years. And then I couldn't get pregnant. I was 39. And so we went through in vitro 3 times. I'm going to have to apologize. There's a helicopter landing. I'm in the hospital, and the helipad's right by me. And so I went through in vitro. And probably the funniest story about that, I went to the private group in town in Milwaukee because we weren't doing it at the medical center. And the main woman looked at me and said, well, would you mind if I teach my partner on you, that she can learn how to do this on you? And as an academic surgeon, I was like, no, I don't want to teach anybody, you know, but of course I said sure. And so the first one didn't take, the second one didn't take, and then the third one was twins, but one didn't make it. So I ended up with Taylor eventually, you know, coming out. But I was like, oh, I can't even get away from teaching when I need my own healthcare to do that. But what was cute about that is the first time I went in through in vitro, one of my partner's wife went into labor. One partner was out of town and a ruptured aneurysm came in. So I was like 14 minutes with in vitro and I had to do a ruptured AAA. So obviously that didn't occur. So then the next time we had a meeting with the call schedule, I said, you know, I need to put down my egg retrieval and in vitro on this call schedule. So I'm doing this 3 times. It's costing me a lot of money. And the last time I had a ruptured aneurysm and it didn't work. And John Town, who's just a wonderful man, he just looked at me, what? So on the call schedule was for the last time I went home and visualized implantation, right, for a week. And then I got pregnant. So John Town really thought he was the grandfather just because he allowed me to be out of office to get it done. But I also operated way too long pregnant, so because nobody knew, right? And so I got pretty swollen. On a Friday, I was doing an open AAA on my husband's father's best friend, and I was so swollen and I couldn't get my hands to the table. So I said, I need to go home. And I was induced 4 days later, and that's too long, especially as an older mother. And after I delivered him, I actually went into right heart failure for 6 weeks. And luckily they didn't tell me it sometimes doesn't get better. And I took 11 weeks off to figure that out. So I would highly recommend the standing thing is really hard in the 3rd trimester. And so, especially if you're older. Yeah. So make sure you tell your partners, put it on the call schedule. If your partners are partnered with another woman, they'll understand that. But I think that back then we didn't quite know what the right story was. I remember too, when I came to Milwaukee to divorce, John Town had asked me too, he goes, do you mind when we have dinner parties and stuff that we bring our spouses because you don't have one? And I smiled at him. I said, well, you know, I actually sort of like your spouses better than you. So I would really like them to come because they, again, they were women because my partners were all guys to do it. So I think being open and honest about it, if you can, you know, as much vulnerability as you can see. I do tease my son. He was frozen for a while before he was implanted in me. And he was the hottest baby in the world. He just sweated and was hot. So when I finally told him there's in vitro in a freezer, and I said, I think that's why you sweat so much. He laughed when he was 4, going, I guess that is true to do it. But I think if you want to have kids, do everything you can. I just had a conversation with one of my women faculty members here as well, who is getting close to 40. And we talked about, you know, taking the time to have that done. Because if you want to have kids, you really should do that. Those of you that follow Instagram, you saw my son got married in April, and we were dancing at a small wedding because of COVID. It was wonderful. And so if you want to have kids, go do that because they will love you no matter what happens in the operating room, no matter if you get the grant or not. They're always there for you. And my son once, when he was 6, asked me at Hopkins if boys could be surgeons too. Because he didn't think boys could. And I almost said no. But instead I said, with your mom's help, you can, because in his world, moms were surgeons and dads were businessmen. And I published that at Hopkins in one of the journals so that they could see that. So I do think sharing your career with your kids is important too, because what you do is real important. And they also will be there for you. One time when we were rounding at UCLA, my son touched a below knee amputation, an older Black woman, and said, this will heal. And she said, who's that? That's some angel, because she was blind as well, had diabetes, and it did heal. So letting them see what you do and how you make people feel, I think is real important.
Well, that's a
Julie, I
great
want
story.
to switch gears. I want to ask you a quick question about, do you think there's a blue ocean for women in vascular surgery? That is to say, do we offer a unique proposition value, something that's really different than the men?
Yeah. Well, my patients will tell you that. I once I was doing an in situ distal bypass on an Army nurse once in Milwaukee. And my son was in daycare and he got a fever to 102, right? So you got about an hour to get over there, right? And luckily it was right next to that. So I asked my partner to finish that because I actually have finished cases. A couple of my partners, the kids went to ED or whatever. And so the next day I told her, I said, my partner did your distal anastomosis because I had to go get my kid out of daycare. And she said, is he okay? And many of my patients saw Taylor around on him. Went back in Milwaukee, I'd pick him up, put him in the stroller, and we'd make evening rounds or whatever. Probably with COVID, you can't quite do that anymore. But my patients would want to know my kids. It made me human to do that. I do think we bring another special sauce, just like people with different ethnic backgrounds and different experiences, different colleges, different gender preference, to do that. Surgeons, we're so stuck on who trained you, right? So when you introduce yourself, you go, well, I trained at UCLA with Wes Moore. Of course I would. That's what everybody says to do it. And we really are regimented. And I say this knowing this is Dr. DEBAKEY, who I had the privilege of meeting before he passed. But I actually think we need to meet those people that maybe aren't trained by those people with any that happen, that actually, that is where you get the diversity, and at Hopkins, we actually started taking our interns that weren't categorical, we would take them from international groups because there were so many amazing international applicants. So we would take them in, for a year or two, and they brought such diversity to our class. This helicopter, because they actually talked about how it was to wake up and you were born in Puerto Rico or Singapore, and how do you get trained, and how do you make that happen? And the United States kids, would go, whoa, that's hard, or they spoke 5 languages, and then they had to figure out how to be popped out of the into categorical positions. So I actually think the diversity makes us appreciate that. And certainly, the other story I'll tell you too, when I went down to San Diego, I'm doing my first open aneurysm at UCSD, and it's Grandma Parker. She's like 82, and I'm 32. And I'm trying to tell her family that this is no problem. I got this, and I could know they were looking at me like, really? So we did her open aneurysm, and she gave me a bracelet from Grandma Parker that I wear to this day, having fixed her aneurysm in 1989. And she also cross-stitched a picture for me that sits on my shelf forever, because she believed in me, that I could do that. So I do think there is something special. And I also think in groups, if your group, your team is diverse, you behave better. You see better behavior on teams of surgeons when there's men and women and those from different ethnic backgrounds. You don't see people quite as cliquey or talking about things that are inappropriate if you have a diverse group to do that. And so I do think bringing the diversity is real important. When I trained, I didn't pay much attention to it. And one of my residents told me just recently, he goes, well, you were just Julie. You ran a great service. You taught us. You did this. I guess we thought you were a girl, but but you made sure we had a snack in the afternoon, and we sat down for a soda and a snack for teaching rounds. And you asked us how we felt every day. And you made sure we got home when we needed to. And he goes, and that was just Julie, to do it. So I do think some of our style and how we do that, and now we're free to be that, whoever that person is. I think that you do bring something special. I know I have a women physician now. I would never not have one. I've had men physicians in the past, but now I got a choice, and Megan's amazing. So I think that there are preferences by patients of gender just because it's more comfortable. And so I think we do bring something incredible to the table. Medical school classes have been 60% women for 20 years. Now we need 60% of the leaders to be women. So what we need to do is to raise our hand and say leading actually allows you to organize the schedule and tell somebody else what to do. So I think getting us in more leadership positions so that the teams that work are amazing is our goal. And my challenge for the next 5 years is to keep empowering women to run things. Because I think that blend is really important for how hospitals work.
So we have one more question from the audience, and it's a perfect question to start wrapping up. The hour's almost here, but and I'm going to rephrase this. So the question is: were you a part of, or have you witnessed important changes with women in medicine? I'm sure you have. So I would say, what can you list the top 3?
Yeah. Sometimes you can be on a Zoom screen and there's nothing but women. Whoa, I had that happen and you just died. I was like, whoa. Or you can be in an OR with all women scrubbed and maybe one guy circulator, to do it. Or I just hired a search firm for a position and it's an all-woman search firm. And 3 Sarahs are my search firm. One has an H. So just the presence of women where you're not the only one, and similar to those with different race, must feel exactly the same way, where you go, wow, to make it happen. The other thing is we're not always going to agree. The 3 of us may have a different opinion of how to do the case, how to behave, how to act, what we wear, what we do. And we need to understand that that's beautiful too, that we all don't have to be like me. You can be anywhere when you want, and you can have a difference of opinion as a woman in medicine as well, too. And I think that's what's beautiful now, is that we can actually have some disagreements about how we look at things and what we do, because now we're different along the way. And I think the other thing is that I sort of showed them this. I picked this up in my gift store today. Here's a little Lego surgeon, and it's a woman. And so as you go forward, my granddaughter will tell me that she can do anything in the world. So I do think that ability to see more women and that it's commonplace. And frequently I make that comment saying, I used to be the only woman. The other thing that used to happen is there were 3 women interns, and when I trained, and they got our names mixed up. Debbie was a tall Jewish gal from New York. Barbara was from LA with long blonde hair, and I had a perm for reasons that I don't remember, and I had curly hair. And they would call us different names. Now, if I was doing something wrong, I wouldn't tell them I wasn't Debbie or Barbara. But if I was doing something right, I would say, I am Julie, to do it. And I don't know why that happens. It still happened with interns I had at Hopkins, too. So I think the mere presence, the differences in women, and then the choices we're making to run hospital systems as well as departments, research labs, I think that's what's really exciting.
Julie, can I ask you how you would turn failure into success? I mean, I'm sure you've done this in your own career, and what would you tell everyone watching?
Yeah. So one thing I say is, don't let a good disaster pass you by. Okay. So when I didn't get the dean at Hopkins, I was like, well, I think they should have. Or I looked at 5 chairs of surgery before I got one. I just talked to a woman last week who said, I looked at a division chief and vascular and they didn't give it to me. I said, but this is the first one you looked at, So when I didn't get that dean's job, or I didn't get that chair job at 2 or 3 other I was given a chair job at Colorado and they took it back. And so because of that, I ended up at Hopkins. So I'm going to tell you, if it doesn't work out, it means you're supposed to go through another door. We used to say if a door closes, surgeons would beat down the door. That's what we do. But don't go through a window because you're going to hurt yourself. It's another door. Or even when I got divorced, I felt like I had failed, that I had gotten married and got divorced and I had failed. But if you don't get that job, it means something else is out there for you. And I think also if you've done a great big operation and it failed, or it clots, or they bleed, or you have a misdiagnosis. That feels awful too. I remember the 2 strokes I've had with carotids. I remember both of them specifically. One was a mom of one of our medical students in Milwaukee, and another was a guy in Los Angeles who was 85. I remember them specifically. Those are failures too, and I still remember them, you know. So part of it is that those make you better. They make you remember, and they also make you go forward in a way that you're even a little better. But at the time it feels awful, and that's okay. You can feel really awful. You can go have a glass of wine, eat chocolate, take a vacation, take a walk. If you can scream out loud if you want. I just took a yoga class last week with my daughter-in-law, and this Turkish gal told us that in yoga you can scream. So she had us open our mouth and stick our tongue out and scream. I like that yoga. So I think you can get real upset about it, but realize there is another door, and all of us have had issues. You know, all of us have had disappointments, and you're going to end up in the boat.
Well, Dr. Freischlag, your advice today was invaluable. Your personal stories make you very human, even though we all put you on a pedestal. Palma, do you have any comments?
No, I completely agree with you, and I could listen to Julie's stories on and on and on, because I can totally relate to so many things that you're talking about, and I feel incredibly blessed that you took this time with Linda and I, and we look up to you like you can't imagine, but everybody watching is looking up at you too, and the impact that you've had is just resounding, and it's just going and going. And I just have one last, I know we have like a minute, but so if you were going to give advice to your younger self, is there something you would say, Julie, you should have done this, or don't do that, or don't worry about this, or what would you say?
I would tell you to have patience with a C. I think I was hard driving. I felt I didn't have enough time, that I needed to go as fast and furious and do more cases, write more grants, be at many places. And sometimes I would find myself running into myself, you know, to do it. So when it gets, I think COVID-19 has taught me too to slow down a bit, do patience with a C, you know, don't be so hard on yourself. Women are so much harder on themselves than men are. I've raised 3 sons. They can do something really stupid on Tuesday and they don't remember on Wednesday. I can do something stupid 20 years ago and I can still remember it. And I think you need to be really not so hard on yourself, have patience, and appreciate all the good you have. Do that 5-minute meditation in the morning where you sit there and go, you know, this isn't bad. I've had good experiences. I'm going to have a good day. I get to do this today. I woke up saying, oh, tonight's the thing Palma asked me to do. And so have that joy in your heart to do it, because we are the lucky ones. You know, we don't have the diseases we're treating.
It's incredible.
Well, thank you so much for being on the show.
Great.
And
I really appreciated that. And for everybody that wants to know, that's a Women at Work in front of Kilimanjaro. That was an oil painting I got years ago that happens to be hanging behind my Zoom these days. And it's beautiful. It makes us realize how all women work so hard.
Well, we're going to see you at VAM.
Yes, can't wait.
I'm so excited for VAM. I can't wait.
That Thursday night, I think we'll never go home. We'll just make that happen.
It'll happen. That's great. Thank you.
Thank you very much.
Thank
It was
you.
wonderful. Have a good night.
Have a good night.
Bye-bye.
Bye-bye.